Hi, this is Dr. Rubalcaba with a review with chest tube therapy. It is important for all of you to review the anatomy of the lungs. Now, each lung is enclosed in what we call a pleural sac that consists of two types of membrane. One is called the parietal, and the other one is called the visceral. In between the parietal pleura and the visceral pleura, there is a space that is called the pleural space. And within that space, there is a scant amount of fluid. The function of the pleural space is to prevent friction between the outer layers of the lung and the inner layer of the thoracic cavity during respiration. It also holds the two pleural surfaces together, creating a negative pressure or a vacuum that helps us or helps the person when the lungs are expanded. As I mentioned earlier, the pleural space is full with fluid, approximately 50 cc's of fluid, and that's just enough. Anything larger or any amount larger than that can help prevent the lungs from expanding completely. Breathing can be compromised, and the lung may partially or completely collapse if a certain negative pressure within the pleural space is not maintained. And some signs that you will see when this is happening is the patient's having shortness of breath, they have increased respiratory rate, increased respiratory effort, and pain. Chest tubes are used as a medical management in order to drain fluid or air or blood to reestablish that negative pressure and to facilitate the lung expansion. Now, what are some causes of injury to the chest wall? It can be a trauma, a motor vehicle accident, a fall, a lung disorder. You can have COPD or have a history of intense smoking. It can be a complication of CPR or a complication from a central line insertion. It can also be used to drain some purulent substances for pulmonary embolism and is used for cancer. Indications of chest tubes include pneumothorax. That's when air leaks into the pleural space, making the lung collapse. It can be either partial or completely. Hemothorax, accumulation of blood within the pleural cavity. It can be used for somebody who's been in surgery, open heart surgery, and they need a chest tube, so that is also an indication. Pleural effusion, collection of fluid around the lungs, and then for pulmonary empyema, which is the collection of pus or infected fluid in that pleural space. The next 4 slides will give you a brief description of these conditions or indications for chest tube. Now, when the patient comes in with any problems related to a pneumothorax, hemothorax, pulmonary empyema, they're going to have some signs and symptoms or cues. And so these are a list of patient presentation that come in with a need of a chest tube. Placement of a chest tube can be either in the around the apex of the lung, which is the second intercostal space. That's when there is air that needs to be drained. If it's a blood or fluid that needs to be drained, then the lung is going to be placed at the base of the lung around the 6th or 7th intercostal space. Chest tubes can be inserted in the emergency room. It can be inserted during surgery, and it can also be inserted at the bedside. So as nurses, it's our responsibility to kind of know where things are so that if your patient is going to have, or they're going to be having a chest tube, that you know where to find the items that are needed for this this procedure. Now, obviously, the doctor's going to write an order for a chest tube and is going to say obtain consent. Okay, this is an invasive procedure, therefore the patient or the client needs to give consent. Not only that they're giving consent, but they understand what the procedure entails. And if you find that even after the physician came and told them that they were going to have a chest tube, they still don't understand, you need to let the physician know so that the physician can do further explaining. So the patient is knowledgeable about the procedure, he's consented, and so then you need to gather some supplies. And always follow your hospital's policy and procedure of how this procedure takes place. What are the steps? What are the supplies? Because there may be some slight differences between hospitals. But you're going to get a thoracotomy tray. You're going to get some lidocaine for the physician to inject the area where he's going to make a cut and then insert the chest tube. An antiseptic, sterile gloves, obviously, a scalpel, and hemostats for insertion, an actual chest tube, suture material, because once the chest tube is placed in, it needs to be held in place, so they do that with sutures, and then sterile dressing material to put over the insertion site. Now, before your patient undergoes the procedure, go ahead and get some baseline information, baseline vital signs, including oxygen saturation. Check your orders and see if there is either mild sedative or pain medication, because it's a painful procedure. Provide oxygen, and maybe this patient needs to be on a cardiac monitor. So again, we talked about 3-lead and 5-lead. So if that's the case, then you need to put them on a telemonitor. And then keep the patients supine with the arms of the affected side above the head. That way it makes it easier for the physician to locate the area and insert the chest tube. This is an example of what a thoracotomy tray, what are the items that are included. Again, depending on your facility, the thoracotomy trays may look a little different. They may not have the same types of supplies and instruments than in other hospitals, but your hospital will definitely have a thoracotomy tray in the supply room. The chest tube is inserted through a 1-inch cut that the physician does in the skin between the ribs. And then the physician will check to make sure that that is the place. Then it will take the forceps and open up the area so that they can introduce the chest tube. And then once the chest tube is connected, once the chest tube is inserted, then it's going to be connected to a chest tube drainage system. And as I mentioned earlier, a stitch in the area of insertion and tape and a dressing should be in place. Once the chest tube is in, that's going to allow for air and fluid to drain into this chest tube drainage system. It's important to note that there's a one-way valve within the chest tube that prevents air and fluid from returning to the chest. This is a visual of what it's going to look like when you have a chest tube that is attached to a drainage system. Now, initial care for the patient that has had a chest tube inserted is obviously you're going to get vital signs, you're going to monitor respirations and breathing. Listen to lung sounds, that's very, very important. O2 set, and always inspect the dressing and note if there's any drainage. And sometimes you may have to change the dressing, and when you do that, you want to assess that insertion site for what we call subcutaneous emphysema, and what that is sometimes that's air or fluid underneath the subcutaneous tissue, which is going to tell you that the chest tube has come out of the lungs and it's in the surface. And these feel like Rice Krispie. And then another important aspect of this initial care is pain management. These are examples of chest tube drainage systems that you may see in the hospital, and it's kind of telling you what are some of the parts of the drainage system and what you need to look for. So usually these drainage systems are disposable. And there's going to be 3 chambers. One chamber is going to be this one over here. This is where the fluid is going to be collected. Okay, and so you will see in the hospital that the nurses, the way they keep an INO, because this counts as an output, is that they mark where, when they come on shift, they mark where the level is, and then when they leave, they mark where the drainage is at that time, and then they count how many milliliters of drainage for that shift. Then there's going to be a second chamber, and that's going to be for water seal, and we use normal saline or water in this area. And then there's a third chamber, which is suction control. And with the suction control, it can be, you can have a chest tube system that is wet or dry. And we'll go over that in a few minutes. In order to create a water seal, normal saline or water is added to the chamber, and it gives you instructions to at what level the water should come up to, if you will. The important thing to know is that water seal allows air to exit from the pleural space on exhalation and when they're breathing out, and stops air from entering the lungs when they inhale. Now, as I mentioned earlier, there are 2 types of systems, suction systems. One is called a wet suction, the other one is dry suction. And so this one is a wet suction, and the difference between this system and the dry suction is that this wet suction uses a column of water to regulate the negative pressure. The difference between a wet suction or a dry suction is, for the dry suction, it uses a mechanical regulator to regulate the negative pressure. So this is what you're going to see, and then there's a bevel here that you will observe when the patient takes a breath in and takes a breath out. The next 2 slides are showing some visuals. This one here is a drainage system and the different parts of the drainage system. Now this one looks like it's dry suction because it has the bellow and it has the dry suction regulator. For your wet suction, it does not have this. It uses water, so there's going to be another column where water or saline is going to be instilled. Okay, and then this kind of gives you some guidelines as to what to look for when you are assessing the patient with a chest tube, the positioning of the tube, what is titling, how do you can tell that there's an air leak, is the suction going as it should. And so this is just a little information for you. Continuous nursing care for the care of chest tube, making sure that the chest tube is free of kinks and occlusion, meaning that there's nothing that is preventing the drainage of the air or the fluid that needs to come out. Again, you always want to keep an eye on your patient, monitor their respiratory status, check and see if they're having shortness of breath, tachycardia. When you're listening to the breath sounds, are there absent breath sounds? Is the patient using accessory muscles? You're going to monitor the drainage in the chest tube, make sure that it's draining. A lot of times, drainage systems get knocked over, and there may be times where you have to start a new system altogether, not the chest tube, but the drainage system itself. And there's always documentation about the chest tube and the chest tube drainage. Check with your hospital's policy and procedure. And you want to keep, in the event that the chest tube itself gets dislodged or pulled, there's some things that you need to have in the room just in case. Two guarded clamps, sterile water, Vaseline gauze, 4x4 sterile dressing, and waterproof tape. Something that you may see in practice is the use of a Heimlich valve drainage system. And what this is, it's an alternative to the chest tube drainage system, the boxy drainage system. And so this is a valve. It's portable and it's mobile, and it can be hooked up to a small drainage bag, and it allows the patient with the chest tube to ambulate. Now, in reality, in my years in nursing practice, I've never seen a Heimlich valve system, but I've been assured that they are still being used. In this slide, I put down some troubleshooting when you have a patient that is on with a chest tube. As I mentioned earlier, if the drainage system gets knocked over, it's going to be really hard to keep an accurate INO, so you have to replace the unit. If the unit, falls, gets knocked over, and it cracks, you're going to have to change it ASAP. If the chest tube is accidentally pulled out, immediately get the petroleum gauze and cover the entrance with and hold it with firm pressure to avoid the development of pneumothorax. And then once that petroleum gauze is on there, then you can put the 4x4 and white tape. And obviously the patient may get a chest x-ray to see whether it's going to be worth it reinserting the tube or not. If the chest tube becomes disconnected to the drainage tubing, there's a policy as to what to do when that happens. But the general, action is to quickly insert the patient's end of the tubing in about 2 inches of bottled sterile water to create a water seal until you get the new system up. If you notice that the drainage has diminished or has stopped, look for kinks or clots in the tubing. If you feel that there's copious amount of blood being drained, or the color has become even more red, this is something that you need to let the physician know about. And there's something that is called milking or stripping the tube. Sometimes, in the tube, you may see some clots, and then you want to just kind of milk it, kind of dissolve the clot. That's a no-no, especially if you don't have an odor. Now, all of this, you'll learn more as you go into your clinical areas, and it would be really great if during your rotations that you have a patient with a chest tube. Last but not least, here are some potential complications with chest tube insertion. I have included a link to a video on chest tubes. It's by a company called Lecturio. You probably heard of it. They have a lot of resources for nursing students. And I looked at this video and I thought it was a really good video and that you all would benefit from watching it. Okay, so let me know if you have any questions about the video or of the PowerPoint, And I will see you guys next week.